Okay, so as we continue to talk about plasticity and learning, let's talk about a shift from implicit, which is unconscious, to explicit, which is conscious knowledge. So, right, going from the unconscious to so after explicit learning of a sequence has occurred, and you learn the task, contribution of the motor cortex, attenuated, and other brain structures begin to assume more active role in task execution. So now we can go shift from explicit to implicit, meaning conscious to unconscious. So practice can result in a shift to implicit memory to explicit memory. So that's where practice comes in. Constant repetition of a task can result in a shift from explicit to implicit memory, driving a car, riding a bike. And use of the two memory systems together, unconscious and conscious, is the rule, not the exception, meaning you must go from the conscious to unconscious. How can I recall it and then put it back in the unconscious, right? Riding a bike, buttoning a shirt, walking, all that goes from your long-term to short-term, long-term, short-term. With brain injuries, we have difficulty going from long-term, short-term. So we can only remember it for a specific time, but then you're thinking, well, Patel, is that even possible? Well, that's where the research is, and that's where we come in as far as rehab. This is where our constant repetition of a task can result in a shift from explicit to implicit memory. See, again, you know this, right? You know that repetition, you know that this works, but now you're understanding the physiology of how we learn a task, right? You understand how the brain works. So interesting stuff. Okay, motor learning. Complex forms of motor learning. There's simple forms. Again, there's that operant and classical conditioning. Pull a lever, get shocked. Pull a lever, get cookies. But then there's also complex forms, which is acquisition of skilled movements. So with practice, changes in sensory motor cortical pathways increase efficiency of the thalamo-cortical pathways co-activated during learning process. So now you're getting complex forms. So now you have to kind of, okay, so if you see this cat, she has to put her paw through this little opening, then she has to put her little paw into this can, which has another small opening, and inside there is a little treat. But with repetition, she can learn that, hey, if I stick my hand through this little paw, little opening, and then go in through a can, then I'll get a treat. So there's more higher level learning there, higher level tasks. And same thing with our patients. We might just start with sitting, but then we might ask them to sit to stand. Then we ask them to sit to stand, then reach, right? So there's higher learning, motor learning going on there. So development of a motor skill shift toward automaticity, right? Making it automatic. As automaticity increases, it's easier to perform second attention demanding tasks simultaneously. So perform the task movement in apparently effortless and automatic fashion. So speaking, writing, talking. So when first task is automatic, then you can add another task. So this is where it's very important for you to understand that if a patient can barely sit, okay, and you're going to ask them to sit, stand, talk while you're talking their ear off, and then reach, it's not going to work because they can barely master the task of sitting. So this goes back to make sure you're not trying to do a task that's too complicated, otherwise you're going to fail. So give me some examples of trying to do too many things at once, or give me an example of where you could start and how you could progress, right? Sometimes walking in general is a good start, but in order for you to walk, you have to be able to stand. So a lot of times if someone can't just stand in place and get a little nudge here and there and on uneven surface, well, how can they ever walk? Right? So, and then while they're walking, you're going to talk in their ear and you're going to distract them even more. So these are all these little things that you don't understand from a neurological standpoint that plays a big role in their activity. Too much stimuli will throw them off a little bit and you won't get the results that you want. So summary of forms of learning: implicit or procedural memory storage, recall of memory without conscious thought. New motor habit requires neostriatum, part of the brain. New skilled motor behavior requires cerebellum. Okay. Simplex reflex learning occurs in sensory and motor pathways, and implicit memory system work in parallel with explicit memory systems, so the conscious and the unconscious. Now again, plasticity, neuroplasticity, which is the brain, level, there's glial and vascular support. There's network level, changes in patterns of neural activation. It happens at the intracellular level, neurons at the synaptic level. It happens at the intracellular level, which is the mitochondria and the ribosomes. It happens at the biochemical level, which are proteins and enzymes. And of course, it happens at the genetic level, transcription and translation. That's crazy, right? That neuroplasticity happens at all those levels. It goes down to the cellular level. So you're thinking, Patel, how do I rehab at the cellular level? Well, you did the best you can, and those changes will occur naturally at the cellular level. But it takes time, it takes repetition, and it takes patience. Conceptualizing recovery, where you have spontaneous recovery, which is initial or early recovery, occurs independent of external interventions. You don't have to do anything. You get that spontaneous recovery no matter what. Then you have activity-induced recovery of function, so improvements associated with specific activities. You were involved in that. Okay, so activity-induced, you helped with that. And then recovery, changes in underlying neural structures occurring in the same time frame. So there's something happening at the neural level that caused that to occur. Now, axonal damage, effects on neurons and neighboring cells. Remember, neurons don't undergo mitosis. Okay, so neurons don't undergo mitosis. So most injuries to central and peripheral nervous systems involve damage to axons. And then axotomy, its injury divides axon into two parts. And the loss of the neuron at the site of injury, degeneration along neural pathways, increasing extent of neural disruption. So it depends on, was there injuries to the central nervous system or was there damage to the peripheral nervous system? Damage to the central nervous system, recovery is slim to none. But damage to the peripheral nervous system, a lot of times nerves can regenerate at 1 millimeter a day. That's what they've kind of documented, about 1 millimeter a day. So, and we'll talk more about peripheral nervous system injuries. That's what you have occur in sports or after knee surgery. But central nervous system injuries occur to the brain, TBIs, stroke, head injuries. Spinal cord injuries are a little bit different. Remember we talked about the different levels. Okay. Now, early transient events that depress brain function. So diastasis is a transient CNS disorder, loss of function in structurally intact brain area. Okay, that's the definition. You have a cytotoxic cerebral edema, accumulation of intracerebral fluid. And then you have vasogenic edema, which is leakage of proteins and fluid from damaged blood vessels. So these are just different types of injuries that can occur that can depress brain function. And knowing what kind of injury your patient had is very beneficial. Now, axonal regeneration. How do they regenerate? Axons within all parts of peripheral nervous system, motor, sensory, and automatic, are capable of regeneration. Like I mentioned, peripheral nervous system, axons can regenerate. Axons in the central nervous system do not regenerate. This is a great quiz question. Axons in the central nervous system do not regenerate. New research shows that maybe with stem cells and maybe with some things, maybe some axons, but for the most part, axons in the central nervous system do not regenerate. But in the peripheral nervous system, sensory and motor, yes, they are capable of regeneration, and it's usually about 1 millimeter a day. Now, how does the central nervous system respond to injury? Let's say you had an injury in the central nervous system. Well, you get intracellular responses to injury. You get formation and regeneration of synapses, denervation, supersensitivity. You get unmasking of silent synapses. You get some neural regeneration. They're going to try regenerative synaptogenesis. You get collateral sprouting, reactive synaptogenesis, and neural regeneration. Okay, so that's some of it is spontaneous, and it goes down almost to the cellular level. Again, I don't need you to be too specific on this, but the main purpose that you want to understand is where is the lesion that occurred. If it occurs at the axonal level, the chance of regeneration is slim to none. If it happens at the peripheral level, then your chances of regeneration is likely. Now, changes in cortical maps after lesions. cortical reorganization, continuously modified in healthy adults in response to activity, behavior, and skill acquisition. So your brain is constantly changing. Those cortical maps are constantly changing. Now, occurs after peripheral injury or CNS injury. So depending on where the injury occurs, the maps in your brain are going to change. If you have an injury to the brain, you have an injury even to the peripheral, these cortical maps are going to change. Okay, our job is to find out what's still active and how can we make the best use of it. A lesion-induced cortical hyperexcitability facilitates cortical plasticity. So we're like, okay, let's find out what is still firing and let's tap into that. How do we reorganize the corticals, right? So alterations in cortical mapping occur following peripheral nerve lesions or amputations. Damage to central neural structures results in alterations in cortical maps and changes in neural activation patterns. So we have to change these neural structures and neural patterns. How do we change that? Well, you do the best you can through repetition and exercise, and hopefully it works, right? And nothing's guaranteed, unfortunately. Cortical reorganization of the affected hemisphere. Let's say it's the right hemisphere or the left hemisphere. Contributions of ipsilateral motor pathways, cerebellar contributions to recovery from cortical injury, activation of brainstem pathways, and the cross-modality plasticity. So these are all things that we need to work on. And again, you're like, Patel, why are you teaching me this at the cellular level? I'm not going to go into neurology, but you may. And understanding how the lesion is affected, the time frame that it takes for this to occur, the difference between short-term and long-term memory will all play a conscious role in how you rehab this patient. Strategies to enhance neuroplasticity and cortical reorganization. So here's the take-home message for the day. How does rehab, how does physical therapy, how does occupational therapy, effective training play a role in neuroplasticity, and how do we reorganize the cortical? Well, if you use it or you lose it, you got to use it, right? Use it and improve it. Okay, so first of all, we got to use it. So we got to use that arm, we got to use the legs, we got to use it. Use it and improve it. So the more you use it, you're going to improve that the ability to do it. Now you get specific. Now, besides just standing, now you're going to stand with your eyes closed. You're going to stand and reach. So you're going to specific. Obviously, repetition matters. You did it one time, now let's do it 10 times. Last time you did it 10 times, let's do it 20 times. And then intensity matters. How hard do you try? Do you do it with weight? Don't do it with weight. Okay? So this is the pattern that you want to do. You got to first try it. Then you got to try it and improve it. Then you got to get specific. Then you do repetition. Then you change the intensity. What happens is most of you try to do repetition. Let's do 10 of those when it's not very specific and they can't even do it correctly. So if you do something that's not correct, the brain is going to learn to develop that pattern, and then good luck undoing that pattern to learn a new pattern, right? So there's one thing of just doing something repetitively, but if it's not correct, you're just going to develop a bad pattern. Think about someone that walks with a limp. If you don't correct that pattern, think about how many times they walk in a day. Maybe 5,000 steps, 6,000 steps. How do you undo that pattern? It's very difficult. Okay, so think about that. Obviously, the effective training, the time matters, the salience matters, the age matters, the transference matters, interference matters. All that matters in as far as training is concerned. A lot of times people say, what is salient? Salience, right? Salient, that's just how important is it? How prominent is it? Right? Is it effective? Okay, so that's saliency or salient. Now, the principles of experience. Principles of experience depend plasticity. Here's the principle. You use it or lose it. Failure to drive specific brain functions can lead to functional degradation, so you definitely want to use it. Use it and improve it. Training that drives a specific brain function can lead to an enhancement of that function. Specificity. The nature of training experience dictates the nature of plasticity. Obviously, repetition matters. Induction of plasticity requires sufficient repetition. You can't just do it one time and expect it to be better. Intensity matters. Induction of plasticity requires sufficient training. You got to work hard, right? If you go to the gym and you just lift 5-pound bicep curls all the time, you're not going to really improve. But then if you go from 5 pounds to 10 pounds to 20 pounds, you're going to improve. Salience matters. The training experience must be sufficiently salient to induce plasticity. Must be important. Must be conscious. Okay. Age matters. Training-induced plasticity occurs more readily in younger brains than older brains. Transference. Plasticity in response to one training experience can enhance the acquisition of similar behaviors. Now that you can stand, now you can stand and reach. Now you can stand, then you can lead to walking. And there's our transference. Interference. Plasticity in response to one experience can interfere with the acquisition of other behaviors. So you have to be careful that you're not interfering with something else that you're trying to do as well. So clinical implications, of course, of research in neuroplasticity help us understand some neural changes that occur following an injury. Experience will strongly influence neural mechanisms associated with recovery and function. So do the best you can, repetition, use something that works, highly motivate the patient, be patient yourself, and I think you'll get good outcomes. Again, neuroplasticity and Parkinson's disease, so that's a slowly progressive disorder. What are the symptoms of someone with Parkinson's disease? They're slow, small amplitude movements, increased muscle tone, rigidity. They have a tremor, impairments in balance and gait. So from an exercise standpoint, you want to be specifically intensive forms of exercise. So maybe neuroprotective in Parkinson's disease. So when we talk about Parkinson's, we'll talk about when's the best time to exercise someone with Parkinson's. What are the best exercises? What are the best times? So by understanding the neuroplasticity, understanding Parkinson's, levodopa and dopamine, and we'll discuss that a little bit later. All right. Rehabilitation therapies and physically active lifestyle can be a benefit through preservation of functional abilities and minimization of secondary complications. So when we're working with our patients, we want to preserve their functional ability, and we don't want them to compensate. So we minimize those compensations and bring out the best in our patients to get the best plasticity, neural plasticity. All right, good job.